for this chapter and chapter 27, anyone want to try to describe for me the difference between allergic reactions and anaphylaxis?
Allergic reaction is mild. Anaphylaxis is life-threatening.
Okay. What about how do we distinguish the difference in the body, though?
Compromised airway.
Compromised airway. Yeah, typically when the airway becomes affected, that's going to steer a change in our treatment. So usually an allergic reaction, the body's system is reacting to an allergen that it doesn't like. And in most cases, if it's just an allergic reaction, which body system do you think is impacted?
Endocrine system.
Not the endocrine system. Where do we get our signs and symptoms from allergic reactions? What are we looking at?
Skin.
The skin. Yeah. So that system, the skin or integumentary system, is typically the first impacted system with allergic reactions. So we will see the signs showing up on the skin, the signs: redness, swelling, hives, itchiness, those types of things. We'll see that usually showing up on the skin. So first indicator for allergic reactions will be whatever we assess with the skin. If the reaction intensifies, it's going to drag more body systems into it. So we'll have those issues with the skin, but as Brian said, we get airway compromise. So as the reaction progresses, we're gonna draw in the respiratory system, the cardiovascular system. We're gonna have some airway constrictions and swelling. So respiratory distress is going to become a factor. And because the respiratory system gets affected, the cardiovascular system is going to be affected. And so when we get these multiple systems being affected, that is when we can categorize this as anaphylaxis. So a simple allergic reaction will most likely only be affecting the skin or the integumentary system. But once it starts progressing and drawing multiple body systems in and affecting multiple body systems, we're going to treat this as anaphylaxis. So treatment wise for allergic reaction, these people that have those skin problems, treatment wise, what are we going to be looking at?
Benadryl.
Okay. Benadryl is going to be our medicine of choice. How much and how do we give it?
IM, and I think is it 15 to 30?
IM is a possibility. The dose is not 15 to 30.
25 to 50.
Okay. So Benadryl, the adult dose, 25 to 50, and we can give it IM. How else can we give it?
PO.
PO. How else?
IV.
IV. So it depends on how we have it supplied to us. the IV and IM routes medicine, you cannot have them drink that. So it has to be specifically a PO route if you're going to do that, if you have those pills, but or the liquid.
And you give
So
them an H2.
what's that?
You give them an H2 blocker.
We can also give them the H2. So in most cases, Pepsid is the one that the ambulances are carrying, or famotidine. So we can do that as well. If we do Benadryl, what kind of reaction are we expecting from our patient?
Them to get drowsy.
Okay, they will, or they should. In most cases, they will. These people are going to get drowsy. Maybe even if you give them 50 IV, they may even go to sleep. So be aware of that. That could happen. So not only will it help them with all of the skin issues that they're having, but it'll make your transport a little more peaceful because they'll probably fall asleep on you. Which will be good. So with just a simple allergic reaction, if it's only the skin that's being affected that we can tell, no airway issues or any others, we would expect to see redness on the skin, hives in different areas or all over, maybe some swelling, itching, those types of things. So our treatment of choice is going to be to start with Benadryl for the adult, 25 to 50 milligrams, and we can do that. It's going to be dependent on how your ambulance supplies it to you. So if you want to do PO, remember with PO, it's just going to take a long time to kick in. So, it'll be 15, 20, 30 minutes before you start seeing anything change. IV is going to be the fastest route. And I'm pretty sure every ambulance has IV Benadryl on it. So that's going to be the fastest route. If you get that to them, it's going to start working pretty quickly. And if for some reason you're having trouble getting an IV established, you can give them an IM injection of it. So that'll work. If you want to follow that up with the H2s, whichever ones you have available, then feel free to do so. That will help as well. And that should resolve their issues. If we start drawing in these other signs and symptoms and start affecting these other body systems, we categorize this as anaphylaxis. How does our treatment change?
Add epi.
Okay, what kind of epi?
1 to 1,000.
1 to 1,000. So what's the dose and route now?
1 milligram per milliliter IM.
Okay, so that's the right route, the wrong dose. What's the dose for 1 to 1,000 for anaphylaxis?
0.3 to 0.5.
Oh shit! Wrong
Yeah,
thing.
0.3 to 0.5 milligrams. So epi 1 to 1,000, 0.3 to 0.5 milligrams. This is an IM injection, and that will help. Should help with the respiratory issues if they're starting to have airway compromise or some swelling, difficulty breathing, those types of things in the airway. Then this should help. What are we going to follow this up with? Once we give the epi.
O2, oxygen.
Yeah, let's give them some supplemental oxygen too. So if they're having difficulty breathing or starting to have some kind of airway compromise, oxygen is a good thing to throw on them. Definitely give them the epi we're probably going to have all of the skin issues that we had. So we're still going to do all of the other treatment that we just talked about. So still give them the Benadryl. If you want to do the H2 blocker and you have it, do it. Do the epi, give them the oxygen. What kind of monitoring stuff are we going to be hooking up to them?
At least a 4 lead.
Okay. You don't get to do 4 leads, Brian.
Capno.
Capno is a big thing. I would encourage you guys to get a 12 lead on these people. Definitely hook them up to Capno. If you want to do Capno and pulse ox, that's fine. But make sure that you're using all of your monitoring equipment and your in your monitor there. The only issue with 4 leads is simply cardiac monitoring, which you guys can't do. So do the 12 lead and you can leave everything there, which lets you see the same stuff. But technically you're not cardiac monitoring because you ran a 12 lead. All right. So one place I'll tell you to check if you're suspecting allergic reactions or anaphylaxis, especially in patients that may not be in a good mental status state for whatever reasons, is don't forget to look inside their mouth and check their tongue. Your book has a really good picture of a patient with a tongue that is swollen, and in allergic reactions, and as it transitions towards anaphylaxis, the tongue will swell, and you can see in that picture just how much it swells. And that is a very vivid swelling. But in your assessment, that could be a key tell for you, especially in patients that don't fall into that A and O category. So if you're having trouble getting any information out of them or anything like that, yeah, get their mouth open, take a look at their tongue, and see what it looks like. All right, the rest of the chapter for 27 is going to round out with autoimmune stuff. So the autoimmune disorders where the body's immune system is essentially attacking the body. We talked about that in the last section with the endocrine system, thyroid issues especially. There's a lot of autoimmune disorders with the thyroid. There, Graves' disease and Hashimoto's and different ones. And so those are in the finishing of this chapter, and as we go into the next chapter, the autoimmune stuff is going to continue with arthritis, different forms of arthritis, and then other illnesses such as AIDS and things like that. So brush up on the autoimmune stuff, and then let's transition over into the infectious illnesses. So what's the hot button right now in the world with infectious illnesses?
Sepsis.
Nope.
Coronavirus.
Coronavirus. that is the hot button topic of the last few weeks. And although it's not a new discovery of any kind, it's probably the first time that most of us have heard of the coronavirus. It has been known and studied for years, but it's never been a real topic of conversation. Although all of these viruses seem to be making their way out of either Africa or Asia for the most part, because those people over there eat weird stuff. So, are you guys familiar with where a lot of these viruses come from, how they originate in people?
Nope.
No. Um, typically,
Population control by the government.
not a conspiracy theory guy, are you, Brian?
Nope.
Don't it come from them eating like animals and stuff?
It comes from it all starts with for the most part it all starts with mosquitoes. So mosquitoes will carry a number of viruses which are all bad for everything in the world. And then what animals that eat mosquitoes, birds, bats, most things flying will eat mosquitoes. And then for some interesting reason, people decide to eat birds and bats. So these not properly cooked, infected animals that people start eating, and then they get sick and they become virally contagious and they start spreading it among the human population. So my suggestion is don't go to Africa or Asia and eat monkeys or bats, because that seems to be where it's all starting. Like, I don't understand why you would eat a fish that you know is poisonous and could kill you if it's not cut properly. Anybody ever done that?
No, but that's a blowtoad, right?
What is it? Is it that puffer fish or something?
Yeah, blowtoad. You catch
Yeah.
them right out here at the piers.
Yeah, but they're extremely poisonous.
Oh yeah, they'll kill you.
And they'll kill you if you don't. You have to cut them specifically so that you don't get the poison. And it's like a Japanese delicacy, and they train these chefs for years and years and years to learn how to cut the thing so they don't kill you when you eat it. I feel like I'll just pass. But that's the origination of a lot of these viruses. We've been hearing over the years about the different encephalitis, the equine encephalitis. You get the bird flu and the swine flu and all of these different things that are coming through and spreading around. Um, the reason that there's such a problem now is because the world has mass transit and we can travel freely around the world in essentially a day. You can get from one side to the other in a day. So these things do not stay localized that well anymore, and they tend to spread far and fast. And that is the problem with this coronavirus. Started in China. They narrowed it down to one concentration place in China, and look at how it's spread around the world with people traveling becoming in contact with folks, becoming infected, spreading it, not knowing, and it's hard to contain. So you just have to watch out. So what we're going to talk about with these infectious diseases and illnesses, first and foremost, is PPE and what we can do to protect ourselves as we're answering these calls. First of all, what do most of these patients look like? If they have some kind of viral infectious illness, what do they look like?
Walking death.
Okay. More specific. Signs and symptoms. How do these things start? What do they present first with?
Like a cold.
Okay. Starts out looking like a cold. How does it progress?
Then they hit a fever.
They hit a fever. So they thought they had a cold. Now they have a fever. What do they think's wrong with them?
They think they have the flu.
They think they have the flu. So what do? Do they stay home?
Nope. They're going to keep right on working.
Nope. They keep going to work, keep thinking they're going to play through the pain, right? So they keep getting out, going around. They're still, coughing, hacking, sniffling, touching stuff, being around folks. And so highly contagious at this point, and they're spreading it around with all the people and places that they visit. So but that's the problem, is that they think that in the early stages they think they either have a cold or they're just they're just getting a little bug, and then as it progresses they think, well, darn, I've caught the flu. And by the time they get to the point of figuring out it's one of these specific type of things like coronavirus or bird flu or whatever, then it's pretty far progressed, and who knows how many people they've come in contact with or exposed to this stuff. So treatment wise for these folks, what are we going to do for them?
Yeah, give them fluids because they're probably dehydrated.
Okay, so IV fluids is a good thing for them. Help.
Tylenol if they have fever.
Okay, fever control. So Tylenol or ibuprofen, however you decide to do that.
And that's about it in the pre-hospital setting.
Okay, so mostly supportive care. That's where we are with these folks. We're going to be managing signs and symptoms. So if they are, like you said, they present like a walking death type of thing, we're going to expect fever, so we can treat that. We're going to expect they haven't been eating recently, maybe nausea, vomiting, dehydration type of thing. So IV fluids is warranted for that. In the extreme cases, they may be heading towards being septic. So we would have to manage, assess and manage for that. So watching the septic things that we're looking for, low hypotensive issues and non-perfusion issues, which again we're going to be fixing with IV fluids. Maybe they'll need some oxygen if they get into that altered mental state type of thing. But yeah, it's not we don't have a really quick fix or a bold treatment for these folks. So mostly supportive care with treating signs and symptoms. The biggest issue we're going to have is working on containing the contagion. So how do we protect ourselves and contain these folks from just infecting everybody?
Can't you put a mask on them and one on you?
That's what I would do. Everybody gets a mask, so they get a mask, you get a mask. What else?
Get yourself an eye shield.
Eye shields. Make sure you're utilizing all your PPE that's available. So gloves for sure. Put a mask on. Eye protection is a good idea. Uh, make sure that you have something on these folks so they're not coughing and hacking in your face. If they do vomit, treat that stuff as highly contagious. Um, don't get around it at all. Stay out of it. Don't get it on you. Don't look at it. Don't breathe it. What about dealing with the receiving facility? Are they going to care that this person is highly contagious? Do they have a different procedure for folks that may be infectious? Do you know?
Stand at the nurse's station waiting
Yeah,
for a room.
they can put the patient on droplet precautions.
Okay. So it's a good thing to call and let them know, give them a heads up that you're coming in with somebody that you think maybe. I mean, they don't really get excited about the flu, do they? Other than giving them a mask or something. Have y'all seen any other precautions that the ERs do for flu type people?
No.
No, they don't get real excited about it. If you were to call them up and say coronavirus right now, would they get excited about it?
They might lock the doors.
Yeah, they might. So it's just kind of weird, but is one worse than the other? Who knows? But I mean, people die from the flu all the time, but now these folks are dying from the coronavirus, and it's a worldwide pandemic problem. Even
So
though they don't get excited about the flu.
what's the treatment for the coronavirus?
It's a viral thing, so there's no antibiotics for it. It's managing signs and symptoms, keeping your body up. The best treatment is going to be your immune system. So they are having to boost your immune system and manage those other signs and symptoms. So if you have a good immune system and you get some treatments early, fluids and those types of things, you probably have a good chance of getting through it. But just like the flu, these viral infections, they hit the people that have the weakest immune systems. So if you're an elderly person, a young person, somebody with a compromised immune system, like folks that are already fighting these autoimmune diseases, like if you have Crohn's or arthritis or some kind of thyroid disorder, those types of people, highly susceptible to these things because their immune system's already weakened. There are some antiviral medications. I don't know how well they work in these cases, but I'm sure with the coronavirus, the people that are sick, they're trying everything. They're throwing everything at them to see if something starts to make a difference. Um, the other issue with infectious diseases, and it's another hot button topic in the United States right now, is vaccinations. So I know we've probably hit on these before, but there's a lot of people that are not vaccinating their kids anymore because they think that their kids are going to get autism or something. And so they stopped, and now there's a big influx of people that are going back to getting measles, chicken pox, these types of things that all of these things are highly contagious, and they spread like wildfire. So a lot of these cities that have these nice herbal tree hugging people living in them that decided not to vaccinate their kids are now they've got populations that they really can't go outside without catching measles or chicken pox or something in that family. So um, something else to deal with and be aware of as you're traveling. If you are traveling and traveling around the country, I don't think we've seen too much of it in Northeast North Carolina, but in other parts of the country, I know parts of New York, parts of the West Coast, they're having massive uh, increases in measles, and they're it's turning into a society issue where they're having these fits with folks and trying to do things to limit public access and that sort of stuff. So um, once they made vaccinations optional, I don't know what they thought was going to happen, because when you make things optional, people aren't going to do it. So now that's what we have to deal with. Um, for those of you that like taking cruises, these cruise ships, just like airplanes, are becoming little breeding petri dishes for these things. So all of these places of mass population attendance and quick turnarounds, they don't get cleaned thoroughly. And so, they'll come in and change the sheets on the beds and that sort of stuff, but I don't know how well they're cleaning those cruise ships. I know how well they're cleaning those airplanes. They're not. So I would assume they're probably doing the same thing on the cruise ships. They're not getting cleaned very well. And that's where these things are just, and I mean, think about cruise ships. People come from all over the world to one ship, then they go back all over the world, and the spreading of those things just goes very far and fast. So if we deal with infected people, what are we going to do when we're done with them, once we get rid of them?
Pretty much got to
Burn
clean down the
everything.
unit.
Burn everything. I like it. What we should do is not that unit needs to be deconned. It really needs to be cleaned, sanitized, and I know it doesn't happen as much as it should, and we're always busy. You may have to leave you dump that patient off, leave from the hospital, go right to the next call. But what we're doing is we're increasing the chance of spreading that stuff around if we don't take the time to get that truck cleaned out. So it's a conscious focus that we need to put into the ambulances is to clean them, and we don't always do that as well as we should. If it's a gross thing, I mean, if people are puking all over the floor in the back or there's blood everywhere, we usually do a pretty good job of taking it out of service and getting it cleaned up. But if it's stuff that we can't see, that's where we kind of fall short. So try to make a conscious effort to think about that and to wipe down all the surfaces. Just because we put them on a stretcher and roll them into the back of the truck doesn't mean they don't touch stuff, right? A lot of times they reach out and their arms will touch their hands will touch the counters or touch the bench seat and different things. So just wiping off the stretcher doesn't always get us where we need to be. But think about that. It's hard, especially when we're pressed for time in a lot of cases, but stuff we can see, we do a decent job with. It's those things that we can't see. And unfortunately, most of these infectious illnesses we can't see. Anybody have any thoughts on that? So this chapter, your book goes through with some information on all of the regular, like bloodborne pathogen illnesses, HIV and AIDS, hepatitis, tuberculosis. Talks about all those things that we normally talk about in the bloodborne pathogen course. It also goes into colds and flu and bronchitis, those types of things. It touches on the respiratory illnesses like SARS and RSV and stuff like that. It goes into the kid problems with whooping cough and croup and different ones, epiglottitis. And we talked about the measles and chicken pox, and those are covered. Meningitis is another one that they mention. And what kind of population is highly susceptible to meningitis? Anybody know the most likely people that are going to end up with it? Anybody know what meningitis is?
It's the inflammation of the meninges.
Okay, so it's an infection, right? The meninges are found in the spinal column, so it's an infection that usually affects the spinal cord. And signs and symptoms. What's the telltale symptom of meningitis?
Is it redness down the spine?
It may be, but that's not the one. The telltale,
Is it stiff neck pain?
yeah, stiff neck pain. They'll be in pain usually with a stiff neck. They won't be able to move it up and down. There's a little test that you can do with folks if you suspect meningitis, is you can have them lift one knee up towards their chest, and if they rotate that hip and bring the knee up into their chest, you'll probably see their head bob down towards the knee, because of that inflammation and the pain that it causes. But stiff neck is the usually the classic telltale. Viral infection. So these people usually look sick. They look like everybody else that might think that they're sick and they have the flu. Weak, nausea, vomiting, fever, that sort of thing. As it progresses, maybe into dehydration, altered mental status, and worse. Highly contagious. And the classic population that this will affect is usually college age kids. In case you guys don't know this, teenagers are filthy animals, and college age kids living in dorms are the prime. That dorm is the prime petri dish for meningitis. The college age kids don't have a very good hygiene arrangement there. What do they like to do? They like to have parties. They like to drink. when they drink, they like to share, and sharing drinks is the number one spread of meningitis. So if you want to screw up a college or university, go to a dorm, pick somebody up, and then say they have meningitis. They will lock that place down. They'll quarantine the dorm. It will become interesting for quite a while. But those are the ones that are most likely to see it. It talks about, in your book is going to go into encephalitis as well. Encephalitis, what part of the body is infected by the virus?
The brain.
The brain. So when they get encephalitis, these are coming from mosquitoes again. The mosquitoes will transmit this stuff, and if you get bit by the right mosquito enough times, it'll give it to you. But then all these other animals like the ticks, it talks these ticks that bite you, and they'll create these viral infections in you that'll lead to encephalitis, which is a swelling and infection in the brain. So we would expect those people, they're going to have headaches, they're going to feel bad, they may be getting into vision issues and altered mental status, all of this stuff because they had a mosquito or a tick bite. So keep those things in mind. What's the tick that bites you and then you can't eat red meat?
The longhorn tick.
Is that what it is?
Yeah, it's the one with the white spot on the back.
They yeah, I forgot the name of it, but I know they have this tick now that when people get bit by it, they can't eat red meat for years and years and years afterwards, which is terrible. Botulism. Where do you get botulism? Where does that come from?
Canned food.
Yeah, that's from eating bad food. So, all the things in bad food now, right? You got the salmonella, E. coli, all of these different bacterial things, which the good thing about those is there's a fix for it, right? Because it's bacterial, there's an antibiotic you can take. But you still got to watch out for that because that's a few days of misery with nausea, vomiting, diarrhea, those types of things. The book goes into mono and herpes, and they've got some very good pictures if you need to puke up your breakfast. You'll see all of those different things. Ringworm, it talks about. So the pictures are good, just to even talks about scabies. The pictures are good just to get an idea of what these things look like if you're not familiar with what herpes looks like, or ringworm, or just different things. These pictures are real good. They'll show you what that looks like. Which is good. And it finishes, they finish with the sexually transmitted infections like syphilis and different ones. So chlamydia, those types of things. So if you don't know what they look like, there's no pictures. You'll have to Google it. Any questions about the infectious stuff? Most important thing coming from that, guys, is protect yourselves. protect the people around you, limit exposure to the contagious folks. So utilize the masks. If the patient tells you they can't tolerate it, make them wear it anyway. They can figure it out. It's not going to be that bad. Stick a nasal cannula underneath of it if you need to give them some oxygen. It'll work. And then the last chapter, we get into this last chapter. It's talking about non-traumatic issues with musculoskeletal and skin. So the things that they're talking about here are skin and muscle issues. It gets into things like decubitus ulcers, gangrene, stuff like that. These things usually occur. Decubitus ulcers usually occur in what types of people?
Bedbound.
Bedbound people, non-ambulatory people, not necessarily folks that are just laying in a bed all day, but even folks that are sitting in like a wheelchair all day. They move out of a bed into a wheelchair, but they could still buy, if they spend 8 or 10 or 12 hours in a wheelchair every day, they could develop these things. Typically, decubitus ulcers are on the surface of the body that's in contact with something all the time or a lot of the time. So most of the time, these things, you'll find them on the butt or the back, or like their heels on their feet. Areas like that are the most likely that you'll see them. What's the likelihood these things are ever going to heal up?
Probably never.
Probably never. Once they get them, they will spend many hours and many days making trips to wound clinics, getting things done to them, trying to clean them out, trying to heal them up. But the likelihood is that they're not going to heal up. So they're just going to have to deal with these things. And because they don't ever heal up, that leads us to the other thing to talk about, which is gangrene. Usually gangrene happens from a previous wound, a wound that won't heal up. And what it is the tissue actually dies and necroses. And in gangrene, it actually, if you've never seen it, you're lucky. If you have, you know the actual green color ring around the wound and the lovely smell that you'll never forget that goes with it. So this the fix for gangrene usually is what?
Amputation.
Yes. Usually if they get to the point of having a wound with gangrene, the fix is going to be amputation, because the reason they have the gangrene is the wound hasn't healed previously. They've probably had it long term, months and months and months or years, and it just won't heal up. So that their fix for this is going to be amputation. Otherwise, this thing is going to spread. They're going to become septic, and they'll probably die. So that's what they go above it to some location they determine, and they start taking away parts. Typically, gangrene starts in the extremities. People with poor circulation, hypertensive people, diabetic people, these folks, poor circulation people, are susceptible. If they're uncontrolled issues, they don't take care of themselves, they get a wound on their foot or hand or something, and it just never heals. And once this stuff develops, then that's the end result, though. From the musculoskeletal side, the book is going to talk to you like a bunch of different arthritis type things. So rheumatoid arthritis, ankylosing spondylitis, those are autoimmune type diseases in the arthritis category. So a lot of those arthritis type things, you're going to see some characteristics in the bodies. You may start to see things that don't look quite normal. They look like things are starting to deform in the joints. People that have those arthritis, their fingers may not straighten out all the way, so they start to curl in. Same with their toes. And you may see it in other joints depending on how it's progressing. Some of the treatment for arthritis is fusing bones, and when they start fusing bones, then range of motion becomes limited. So if you're checking range of motion in people and they don't have full range of motion, this could be some assessment type direction to go in, is getting that history and finding out if they have any type of arthritis, if they've had any type of surgeries or bone fusions for it. So make sure that you're looking into those things as you're getting your assessment done on these folks. Arthritis type people, what's the complaint? What do we normally deal with these folks? From an EMS response scenario with arthritis type people, what's the call going to be?
Maybe like a fall.
Okay, that's probably going to be like one of the top two. I would say that these people, you're either going to go to a fall or you're going to go to some type of pain call. So they might be in pain, or they fell, or they fell and they're in pain. These people are probably susceptible to broken bones. We know the osteoporosis type people are. Most, a lot of everybody that has arthritis is not old. There are some young people with arthritis, but I would say the most of the population arthritis people are older. So I would put them susceptible to falls and bone issues. So be careful with the assessments. Make sure you're checking the obvious places, joints, hips, neck and back. And then once your assessment's done, if you don't know or think if anything's broken, we'll treat them and transport them accordingly. Pain management for these folks, we really don't have some good choices, right? If it was a fall and we're not sure about broken bones, Toradol becomes a real iffy. But in a lot of cases of arthritis, these people have pain management on their own, which is better than what we can give them at this level. So if you got a medic that can get some good pain management with you, then that's great. Otherwise, it's more of a supportive care type of treatment for them. All right. Anybody have any questions, anything they want to discuss out of this stuff?
Nope.
Again, three chapters this week. They're fairly brief in the the number of pages. There's a good amount of content for them, but a good read for you. Make sure that you guys are, again, staying in the chapters in the book that you're reading and getting through this. The module exam is coming up in about 2 weeks, so it's going to be a ton of information spanned over 13 chapters in the book. So again, this is the biggest one, and it's going to take some work from you to get through all that information. Labs this week: tomorrow night in Perquimans, Thursday morning in Elizabeth City, and I think that is it.
Is it 3 hours or 4 hours?
The labs this week, they are 4. So 6 o'clock tomorrow night, 8 o'clock Thursday morning. All right. Again, if you're needing to get Cameron some stuff, do that. You should be getting some information back from her if you've already sent it. She should be getting you back your approvals and letting you know when and where you can go. Focus on those skills that you still need, and work towards the team lead stuff. Again, I'm not saying it's going to work like this in the field, but our envision of team lead when you get to that point is you have 2 people with you because they're the ambulance crew and you're the student. And one of those 2 people is your preceptor. So you and the other person should be able to handle that call completely, and the preceptor can stand back, hands off, and watch and make sure that you're doing all your stuff correctly. But that is our vision, is that preceptor can sit back and be totally hands off while you manage this patient appropriately. So that's what we would like to see. That's what we hope you work towards, and that's what I hope happens in the field, and I hope these preceptors can allow you to do that. All right. Anything else? Okay. If you guys don't have anything else, I'm not going to hold you today. We'll get out of here early and you can get on with the other things you need to be doing. I'll see you guys in the lab. If you're there tomorrow night, I should see you. And if not, I'll see you next week.
Alrighty.
All right.
All right. You guys have a great day.
You too.
Natasha, are you still there? Hey, Natasha. Hello. Hello.
Hello.
Hey, you do you have some issues that you want to talk about, or is something going on?
Oh, it's just life.
Oh, okay. I didn't know if there's something that
Yeah,
I
and
needed.
to top it off, just as class started, my radio went off. My neighbor just died.
Oh, huh.
So it's just been a really shitty week.
I hear you. Okay.
I mean, last week the tornado tore shut up. Yesterday I responded to my crew getting hit by a car, and today my neighbor dies. So
Well, they say it happens
yeah, I
in
got a
threes,
few issues.
so that's three. May,
Well, I
may,
only voiced 3.
maybe you'll get a break now. Okay.
I hope so.
I just wanted to be sure there wasn't something in the class that I needed to know about or deal with.
No, my only thing with the class is I'm saturated in as far as I don't want to look at any more gut problems. I don't want to hear any more abdominal nothing. I really don't. I'm
Yeah.
not kidding. Last Thursday, you could have asked me, where's the kidney? I would have said, in your belly. Shut up and get out of my face. I couldn't even break down the quadrants. And
Hmm.
it's so simple that I just went flat out stupid.
Yeah, and it happens. And like I said, we're seeing more and more of it. So
Yeah.
for whatever reasons, I haven't come to a good determination with, but it's more and more of it happening.
Well, the chemicals in the food, the chemicals in our medication, the chemicals in our household cleaning stuff. And,
Yeah.
we're eating shit we're not supposed to, that's not, not designed for us. The